Thank you, Karen. I'm a novice at this, so please bear with me. Unlike my opponent, I have no conflicts of interest and no disclosures. And unlike my opponent, I'm going to focus on level 1A evidence, that is to say, IPD meta-analyses of large randomized trials. In contrast, my opponent is going to focus, I imagine, on level 6 evidence, that is to say, gossip, smear, innuendo, and tabloid journalism. So, as Professor Jaffe said, lower is clearly better for LDL reduction. The evidence for this comes from the CTT meta-analysis. When you look at the results of the trials that have been done, there's a clear, direct, proportional relationship between the intensity of LDL reduction and the benefits. You see, if you have trials of ineffective or moderate agents, you get a low reduction in major vascular events. But trials that really aggressively lower LDL cholesterol, you get very profound event reduction. And the PCSK9 trials sit up at the very top right-hand corner of this line. So if you get a patient with an average cholesterol of around LDL cholesterol of around 3.5 to 4, you give them a statin, a moderate dose statin, you push their LDL cholesterol down by around 1 millimole. That gives you a 21% reduction in risk. Push them a bit further, reducing their LDL cholesterol by a further 0.5 of a millimole, you can get even lower MVE rates. That's a 33% reduction per 1.5 millimole reduction in LDL cholesterol. And as we've heard, it's now quite easy with generic high-dose statins to achieve a 2 millimole reduction in LDL cholesterol, which can give you a 40% reduction in major vascular events. But to the title of my talk, what about the elderly? So I'm going to look here at the results of 28 randomized trials, over 180,000 participants, of whom around 15,000 were over 75 years at entry, and a median follow-up of 5 years. Overall, there was a clear, consistent reduction in major vascular events of around 21% per millimole cholesterol load, and this was consistent in each of the age ranges studied. My opponent would say, oh, there's a trend towards a reduction in benefit in the elderly, but this trend was non-significant. And actually, if you exclude the results of 4 heart failure and dialysis trials in which statins don't work, these trials include a disproportionately large number of elderly patients, so confound our ability to look at the effects of age on statin efficacy. So if you exclude these trials, as shown in the bottom plot, this non-significant trend disappears. What about vascular death? Well, overall, there was a 12% reduction in vascular death associated with statin therapy. There was a significant trend towards a reduction in this benefit with increasing years. But again, if you exclude those 4 heart failure and dialysis trials, this trend becomes non-significant. So what about the effects of statin therapy on secondary prevention with age? These are the patients we see in clinic with advanced proven arterial disease. And on major vascular events, there is a clear and consistent reduction in major vascular events in each of the age ranges studied for secondary prevention. What's more interesting, I think, is the effect of statin therapy in primary prevention in the elderly. And here it is less clear. There was a trend of diminished benefit in the elderly primary prevention population. And this is a question which is being looked at in an 18,000 patient trial in Australia, randomizing 18,000 patients aged 70 or above to Atorvastatin or placebo. And that's an interesting trial, the results of which are awaited in around 4 years' time. So all effective treatments have side effects, but on balance, statins are safe. And we need to weigh up the absolute benefits with the absolute harms. The benefits are significant, as we've heard earlier. In high-risk patients, a dose of around 40 milligrams of atorvastatin or higher will lead to around 12% fewer major vascular events over 5 years. Counterbalance that with the increased risk of adverse events. Myopathy, 0.05 more. Hemorrhagic stroke, 0.05 more. New diabetes, 0.05 more. Totaling around less than 1% increase of adverse effects over 5 years. So the balance is massively in favor of statin therapy. Briefly, no excess risk of vascular death in any of the age ranges studied, and no excess risk of cancer or cancer deaths in this meta-analysis. So putting it all together, statins produce significant reductions in major vascular events, and these benefits are irrespective of age. there are larger reductions in LDL cholesterol will lead to greater absolute reductions in major vascular events, and statin therapy is safe. There is some uncertainty about the use of statins for primary prevention in over 75 years old patients, and this will be addressed in the STAR-E trial. So in conclusion, we must treat our high-risk elderly patients with high-dose statins. Thank you very much.